So perhaps we should start. Welcome, everyone. Thank you very much for joining us this evening. It's another webinar in the AONM series. We're absolutely delighted to have this very, very renowned roundtable of speakers today. It's Professor Robert Bransfield, who you'll all know from previous webinars that we've been honored to have him on, and Dr. Rosalie Greenberg, who authored the groundbreaking article together with him, and their colleague, Dr. Charlotte Mao. That article was called Microbes and Mental Illness, Past, Present, and Future. And I'll be putting the link to it in the chat right after this. Absolutely stunning article, very, very detailed, and they'll be covering some of that today, but there will of course be time for questions. So I think rather than reading out the biographies of everybody, which was in the email that you received and the e-blast, I'll just mention that Professor Bransfield is board certified by the American Board of Psychiatry and Neurology in Psychiatry, and he's the clinical associate professor at Rutgers Robert Wood Johnson Medical School, and also works in private practice. So he'll be telling you a little bit more about his work in a minute. And then Dr. Rose Greenberg is a board certified adult, child and adolescent psychiatrist known for her expertise in the diagnosis and management of complex psychiatric problems in children and pediatric psychopharmacology. And Dr. Charlotte Mao is a pediatric infectious diseases physician with a special focus on Lyme disease and associated infections. So they'll each have a presentation, and then about 40 minutes in, we'll have 20 minutes or so for questions. So thank you very much, all of you, and hugely looking forward to this. Maybe Professor Bransfield, you'd like to begin?
Okay, I'll start. I'll show some slides here that will get us started with just generally to give you, to start this off. Now, we're talking about this article we did. It took us 2 years with 100 revisions. It was a monstrosity to do, and over 500 references, but it was something that had to be done. Looking at what's the link between infections and mental illness, and looking at it in a comprehensive way. So the three of us had different backgrounds, and we looked at it in different ways, and it really added a lot to it. So the first thing we did was we made a list reviewing the journal articles. What are all the infections that can be associated with mental illnesses? We have a list of spirochetes, including Borrelia, but relapsing fever, leptospirosis. Then we had other bacteria, and it was quite an effort putting this list together. But then we also had a list of viruses, parasites, and fungi. And there's different degrees of evidence with each of these infections. Then the next thing we did was we looked at serious mental illness. Serious mental illness is schizophrenia, autism, bipolar. And we looked at depression and anxiety. Those are the 5 mental illnesses that are most associated with disability. And what are the infections associated with that? And we also looked at homicidality, suicidality. So in regard to autism, we found around 20 different infections associated with it. Now, sometimes these are congenital or early development. One issue sometimes comes up with is the microbiome in the gut. Interesting, the microbiome in the gut is somewhat similar to what we see with Parkinson's. So now what I found on each one of these lists, Borrelia and Bartonella appeared. Those were the 2 that appeared everywhere. And other infections appeared on some lists, but not on others. So this was a list with autism. And a lot of it, it's the infection, and then there's an immune reaction and how that affects development. So it's a very complicated pathophysiology, but can start with the genetic vulnerability and an environmental trigger, which may be an infection or some other trigger. So these are the infections. Then with schizophrenia, another long list, some of the same things that we saw on our last one. Again, like I said, there's Bartonella and Borrelia on all these lists. We see toxoplasmosis on this. We see syphilis, etc. Then the next one was bipolar illness. Dr. Greenberg is a specialist with children, and when she did an analysis of her childhood onset bipolar illness, like 80% of them tested positive for tick-borne disease. I guess she can talk about more about that later. Then the next was depression. Again, you saw some of the same infections that keep reappearing. Then with anxiety disorders, and this also gets in the area of PANS and PANDAS, which we'll talk about later. But again, Borrelia and Bartonella is on all these lists. Next, we looked at suicide, and there were certain infections that were clearly associated with increasing the risk of suicide. Suicide's complicated, but infection can play a role. I've done articles on this, so has Dr. Fallon, and this has been studied quite thoroughly. And then this is a good example of suicide with Lyme disease. This was a patient who drew some artwork who was feeling suicidal and then went on to commit suicide. And if you look at what's in his head, and a lot of people describe intrusive symptoms that invade the privacy of my mind. And look at how helpless and weak and febrile he appears in that left image, and the torture that's inside of him. Then this is aggressiveness, and aggressiveness is associated with a number of different infections, and also we have animal models. Then we looked, this is an article that just came out more recently where I looked at Lyme and substance abuse. We had a biopsy, autopsy, excuse me, and it was someone who was not adequately treated, then went on, he deteriorated, then turned to substance abuse, and substance abuse got worse, and then he committed a homicide and a suicide, and we examined his findings afterwards and found spirochetes in his heart and the pancreas and inflammatory changes in the brain. So we have to pay more attention to the connection between inadequately treated infections increasing the risk for substance abuse. Then this is basically a model of looking at how these things fit together to reduce some of the complexity. You have the infection or other disease contributors, then you have an immune reaction to it, and then you have the symptoms. All three of these things interact. What starts it may be different than what perpetuates it, but breaking it down in this area is a good starting point in terms of looking at how to approach treatment strategies. So now that's kind of an introduction. So now I'm going to go on to Rosalie, Dr. Greenberg, who's going to talk some, and I'm going to show her slides and she can describe them. And then we'll speak. Dr. Mao is going to talk about testing. And so this is another part of the article where we then looked at models of different infections. We looked at syphilis, toxoplasmosis, COVID, Lyme, and tick-borne disease, and then strep, group A, beta hemolytic strep, and PANDAS. And, looking at those areas in more detail. So let's start with the infections and psychiatric illness with PANS and PANDAS. Dr. Greenberg, do you want to go with this now?
Thank you. Absolutely. Well, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections is much more easily said as saying PANDAS. And this was initially observed by Dr. Susan Sweeto at the National Institute of Mental Health. And she published a study in 1998 where she looked at a number of kids who had had streptococcal infections. And we know that streptococcal infections are associated with, you can go on to have rheumatic fever, you can have heart damage, damage to your heart valves. It can cause a movement disorder that's called Sydenham's chorea. And it can do a bunch of things. And so what was noted in the literature and what she observed is that many of the kids who had strep infections and went on to get these complications like Sydenham's chorea showed a lot of obsessive compulsive disorder. Or many had tics, tics, which are motor tics, which are twitches. They're involuntary. They can be very complex. You can have eye blinks, mouth opening, or just different types of movement. And tics are actually probably the most common movement disorder seen in childhood. And so it's very natural to have them and then for them to go away. But in PANDAS, it's a sudden onset of post-streptococcal infection of a tick-borne disorder or obsessive compulsive symptoms. And it's very interesting because it's like the child was fine. And many times what happens, the parents say, and then he woke up the next day and he was so different. It was like, somebody cast a spell on him overnight or something like that. And often when you get the history, if you're careful, you can often find a streptococcus infection, which means a strep throat, which all kids get, and that's normal. But having a neuropsychiatric reaction really depends on a lot of factors, and especially like your genetics, as well as your immune system. So that's why not everybody is going to develop tics or obsessive compulsive disorder after exposure to a streptococcal infection. And actually, these infections, these symptoms are recurrent symptoms, and they can just occur in episodes. So a kid may have the tics for a few months and then have a year of seeming fine, and then suddenly it comes back. And actually, by the time I see many children, it looks more like a chronic type of condition because they've had it so many times that they don't necessarily go back to baseline after the first or second or third episode. And so they may be left with some of the symptoms, and then suddenly you get an outburst, an exacerbation. So PANDAS itself, the name tells you just about everything. It's pediatric. It's kids between the ages of 3 and puberty. Autoimmune, which I will explain after, but the main thing is that this is thought to be an autoimmune disorder precipitated, neuropsychiatric symptoms, that's your N, after a streptococcal infection. And that's your initiating factor and your causal factor. Okay. And so the main symptoms, what she found is there's this group of kids, and it's estimated that perhaps 2% of children have PANS or PANDAS. And so when they have this episode, okay, you've got the main symptoms. You've got to have either tics or, and that can be motor tics or vocal tics, like throat clearing or coughing or something like that, sounds. And with this, the kids have a variety of associated symptoms and mild abnormalities, including mild neurologic abnormalities, in that they may become physically more hyperactive. Or if you ask them to stick their hands out, they actually can have fine finger movements and can't keep their fingers straight, kind of what's called piano-like movements. So, okay, the primary symptoms, OCD and tics, but then the associated symptoms. And that would be the next slide, Bob. When you have PANDAS, I'm still talking about PANDAS. Often these kids have a variety of other psychiatric symptoms. And that's part of what confuses everybody, because they may look like they have the sudden onset of attention deficit disorder. Suddenly the kid, he can't pay attention that well. or separation anxiety. Separation anxiety can be manifest in many ways. Very typically in kids, they want to sleep with their parents at night. Why? Because nighttime is time of separation. Who knows what happens when you fall asleep? So it's scary. And they have problems. They don't want to go to school. And that's often why they present to a psychiatrist. And they may make up reasons why they don't want to go, but often they'll say, I don't know why, but I just can't. And so it's tremendous anxiety. They're moody. They can be depressed. Their mood can change from one second to the next. And interestingly, they can start showing learning difficulties in that their handwriting may become poorer because of an effect on their fine motor skills. So sometimes I've had parents say, go back, look at 3 years ago before this started. Look at his notebooks. Is his handwriting different? Is it worse? And it's amazing what you see. Also, these kids may suddenly have a recurrence of bedwetting, even though they've been dry for years. Or they may have to urinate frequently during the day. And, your pediatrician, of course, should check out for urinary tract infection, but it's more of that kind of feeling. Or they may have joint pains and things like that. Or you'll get regressive, more immature childlike behavior. Okay, on to the next one, Bob. So what causes it? Well, that's the A in PANDAS, or it's thought to be the autoimmune reaction. What happens is the child gets a strep infection, be it a strep throat, or other kinds of reactions. You can even have a strep infection around, your private parts. And that can result in your body having an immune response. The body creates antibodies. That's our fighters. That's our army that's out to go and get rid of those strep bacteria. The problem is that army can make mistakes. And that army, when it gets into the brain, can then attack a certain area of the brain, which is called the basal ganglion, which is very important because it is important for movement, for learning, memory, a whole bunch of things. So basically, your own body is creating that army that's attacking you because it thinks it's the bacteria. And that process of thinking that the body part is strep is called molecular mimicry. It's similar. It seems similar. So it's important to remember, it's not that the bacteria itself gets into the brain. It doesn't. It's what happens in the immune system that's causing the issue. Okay, Bob, next one. Okay, right, PANS. Now, PANS is interesting because what happened is Suito and the other person found that there were a lot of kids that didn't have strep infections, but they had other infections and then developed a variety of psychiatric symptoms. So she and a group of experts got together and coined the term PANS, which is Pediatric Acute-onset Neuropsychiatric Syndrome. And again, here the acute onset is either of obsessive compulsive disorder or restricted eating disorder. And I think that's very important because eating disorders, we think usually of anorexia, disturbed body image, or bulimia and inducing vomiting. But often the restricted eating in these kids is because they're afraid of vomiting. They're afraid they're going to choke. It is these fears that prevent them from eating. Or maybe they have magical thinking in that if I eat that, then something bad's going to happen to a family member. And of course, for some, it may be a distortion in body image and seeing themselves as fat when they're not. Okay. But then, just as in PANDAS, you have a variety of associated symptoms. That would be the next slide, I hope. Okay. 1 in 5 kids with PANS have the restricted food intake. But here you go. In terms of PANS, you've got to have at least 2 additional symptoms, see, is the restricted eating or the OCD. And that can be, again, behavioral regression, mood changes, urinary symptoms, poor school performance. And in PANS, you don't know necessarily what the cause is. The name itself gives you no sense of what's causing the problem. It is felt to be, again, a trigger type of autoimmune reaction, in which the immune system, again, affects this area, the basal ganglia in the brain. And that could be either antibodies from the periphery of the body going into the brain, or even immune systems in the brain creating their own fighters that will attack this area of the brain. But PANS could be induced by any type of infection. I've seen it with Lyme, I've seen it with Bartonella, mycoplasma pneumonia, a whole bunch of toxins. So there can be a variety of just initiating events. So, but the name itself doesn't tell you causality. And I just want to show you this next slide. If you look at closely, it can give you a very big headache because it is so full of information, but it also shows you the complexity of diagnosing and figuring out how to treat these youngsters with PANS and PANDAS. And it's a diagnostic flow sheet. It can be found on the PANDAS Physicians Network. And it just shows that these are not, it's not like you just give a kid, okay, he had a strep throat, now he's got the ticks, just give him, you know, a penicillin and he'll be fine. This is complex in terms of how this all is affected. And we have a lot more of these cases. We're seeing a lot more of these cases. And so we need to be aware of that. An intervention, usually, because it's in part an immune disorder, intervention will be addressing the immune system. And that may mean giving things like ibuprofen, or some kids may need steroids, some kids may need IVIG or plasmapheresis, a whole variety, or you know, get different antibiotics. Again, depends upon the causality and the symptoms, and of course the individual. And I think I've said a lot, so I'll stop there. Charlotte, Dr. Mao.
Okay, hi. I'm going to turn a corner and talk some about Lyme testing. Lyme disease and associated infections is one of the 5 categories of infections that we focused in more detail in our paper, and want to specifically talk more about Lyme disease because it has such a panoply of neuropsychiatric manifestations. It can essentially, you know, if you want to say mimic or look like so many other psychiatric conditions. And there is a lot of confusion around Lyme testing. So if you're going to want to be working up your patient to know if Lyme might be a factor in their neuropsychiatric presentation, you need to know more details about the testing. So let me share my slides now. Okay. Go into play. Okay, here we go. So I'm going to try to talk about Lyme testing without having viewers' eyes glaze over, which can happen sometimes when you get into the nitty-gritty of diagnostic testing. I'm going to keep it simple here by focusing on one study that actually serves as the sole basis for the interpretation criteria of a type of Lyme antibody testing called Western blot or immunoblot for IgG antibody. So to quickly review, most The most commonly used Lyme testing is serologic or antibody testing that looks not for the organism itself, but an antibody response made in response to an infection with the organism. This on the left shows the CDC's MMWR report from August 1995 that announced what have been the standardly accepted diagnostic criteria for interpretation of a Lyme Western blot or immunoblot. These were decided upon at the Second National Conference on Serologic Diagnosis of Lyme Disease that was held in Dearborn, Michigan in 1994. So you sometimes hear these called the Dearborn criteria by old-timers. What's rather surprising is that the interpretation criteria for IgM antibody and IgG antibody are each based on only a single study. You can see on the left the recommended interpretation criteria and the single study on which each is based. Highlighted in green are the IgM criteria and the study that serves as the basis for it down below, Engstrom, Shoup, and Johnson. And then highlighted in yellow are the IgG criteria and the single study that serves as the basis for it, which is the Dressler and Steer study. On the right then is shown an example of two different strips from actual Western blots or immunoblots, where the different so-called bands can be seen. Each of those bands represent antibodies to different proteins of the Lyme organism, Borrelia burgdorferi, and they're separated on these blots by their size, which is referred to by the numbers that you see on your patient's lab reports or here on this blot. You can see at the bottom, 18 refers to 18 kilodaltons. That's the smallest protein, and at the top, 93 kilodaltons is the largest protein. Note that the two circled bands are 31 and 34 kilodalton bands, that they represent two outer surface proteins of the Borrelia organism, OSP-A and OSP-B. And although these bands are highly Borrelia specific, they are not included amongst the so-called 10 CDC select bands that you see highlighted in the yellow on the left there. OSP-A is in fact the protein on which the old Lyme vaccine that's no longer available for humans was based. It is, along with OSP-B, a Borrelia specific protein. So a standard lab report will tell you which of the 10 select bands, the ones highlighted in yellow, were detected in your patient's sample. And if 5 or more bands are present, that's considered a positive IgG result, according to the CDC MMWR criteria. But it's important to not simply count up the number of bands, but to know which of those bands is highly specific for Borrelia. And also remember that there can be other bands like OSP-A and B that are Borrelia specific, but are not included amongst the standard 10 IgG bands that most commercial labs test for and report, but which are included in some specialty lab tests. So basically, if you have a patient whose clinical history is strongly suspicious for the possibility of Lyme disease, and you have some highly specific bands present, but not necessarily 5 of the 10 so-called CDC select bands, it may very well still be possible that Lyme could be an explanation for your patient's symptoms. You have to consider the entire clinical context and see lab testing as supportive or not of a clinical diagnosis of your patient's condition and not definitive of it. So I want to go into a little more detail on that one study that serves as the basis for the IgG immunoblot criteria, which is this study by Dressler, Steer, and colleagues from 1993. There are a number of explanations for the limited sensitivity of Lyme testing, but rather than go into all the different reasons, it's easier to just show that this one study that serves as the sole basis for the IgG criteria, in fact, shows limited sensitivity for patients with neurologic disease compared to those with arthritis. So this study consisted of two sub-studies. There was a retrospective study from which they generated their proposed interpretation criteria, which ended up being having 5 of the 10 select bands that I mentioned in the previous slide. And then a prospective study in which they tested these interpretation criteria. And what I want to point out about the study first is that each of the sub-studies were quite modestly sized. You can see that in the retrospective study, there were 4 different disease categories of Lyme patients and only 25 patients in each of those categories, which were erythema migrans, meningitis, arthritis, and then late neurologic disease, which they defined as either encephalopathy or polyneuropathy. In the prospective study, it was similarly quite modestly sized, and you can see that of the Lyme arthritis patients, there were 25 of those and only 29 of the patients with active neuroborreliosis. And then when you actually look at what the sensitivity of their proposed criteria were for neurologic patients, you can see that in the retrospective study for meningitis, it was only 64% sensitive, and for late neurologic disease, 84% sensitive. And then when they applied those criteria to a prospective panel of patients, the sensitivity was even lower for late active neuroborreliosis. It was 72%. And this is in contrast to for arthritis patients, where it was 96 to 100% sensitive. So there were subsequently 2 independent studies that used reference samples from the CDC and also used the CDC recommended interpretation criteria. And they reported similarly low or even lower sensitivity, 43% in one study and 44 to 74% in the other. Then several subsequent studies have reported higher sensitivity in the high 90s% to 100%, but for late Lyme disease, I should note. But it's important to know that there is selection bias inherent in the study design of these studies. And their inclusion criteria required that patients have lab confirmation by CDC surveillance criteria, or even in some of the studies that the patients have a positive 2-tier serology to qualify to be included. So not a surprise that then those patients, if that was an inclusion criteria, would have a positive Western blot by their designated criteria. Furthermore, the studies that did separate out figures for arthritis versus neurologic patients showed that there were few late neurologic patients. In one study, it was only 2 patients, and another, it was only 11. And in fact, in both of those studies, half or more of the very few neurologic patients also had a current or previously treated arthritis. So all the different studies are listed there, as well as our paper, where we did a critique of this. And these details are important because, as I mentioned before, the sensitivity of the Western blot IgG criteria are much higher in arthritis patients than in neurologic patients. So that is just the presentation I wanted to do on Lyme testing. We can discuss other diagnostic testing if people have questions about that, but that's it for the Lyme testing for now.
Stop your, okay.
I'll stop my sharing. So, there we go.
Fascinating. Thank you, all of you, very, very much. One question to you, Dr. Mao, because of what you've just talked about. Was there a particular reason why the outer surface protein A and B were left out if they're so very specific? Was that a particular selection bias, or was it just not known at that time that they were so specific?
Yeah, so in the study, in that Dressler-Steer study, they said that although the bands were seen in some patients, they aren't commonly seen, and that they didn't add anything additional to their proposed diagnostic criteria in their study. Some people have speculated that perhaps an issue was that Lyme vaccine was being developed at the same time, and it would confuse the picture, because if the patient had antibody to OspA, then you wouldn't be able to tell if it was because they got Lyme vaccine and made an immune response to the vaccine, or if it was because they had the infection and or disease itself. Not entirely clear, but there's no reason, I think, now not to include it.
No. Okay.
One comment about that. I'd like to make a comment. Well, I think a lot had to do, they were planning on developing those as for vaccines, but when we did a study with autistic children that had Lyme disease, 92, 94, I forget the exact number, % were positive for OspA or OspB. So when you exclude that, you miss cases of autism associated with Lyme disease. It does a great disservice to that population.
And I just want to add a comment in terms of, I spoke to someone who had been at that meeting where they had, Manchester, where they had spoken about, what should be the criteria. And he said to me, well, we knew a vaccine was coming. We thought so. And, it would be then important for a physician to ask a patient, have you had the vaccine? Because that will produce a false positive OspA and OspB. And so then it would be left up to the physician. And so the idea that it was probably easier to just eliminate those bands, so whether the physician asked or not, it wouldn't be an issue. At least this is what was told to be by somebody who attended the meeting.
Oh. But as a result, you're missing out on, for example, that large cohort of autistic children.
Stuff.
Yeah. If you're using that kind of testing. Yeah. Thank you.
Absolutely.
Well, Dr. Greenberg, you mentioned in your presentation that the criteria for PANDAS is, I think, young age, like 2 or 3 to teenage. But there is a question here. Surely the criteria can apply to adults as well. Dr. Ahmet says PANDAS symptoms are also seen in adults, the same features, fluctuations, etc.
That's absolutely true, I think. Okay, we need studies to prove that. But a number of practitioners have expressed to me that they have seen clinical evidence of the same thing. So saying pediatric is really a misnomer, because we're focusing on one group and actually can be seen probably at any age. But we do need studies to be able to prove that. And at least we do have this evidence in children at this point.
Thank you. I'll read a question from Dr. Jardin, because one that she sent in previously does relate to what she's asked here. The link between long COVID and obligatory intracellular organisms looks obvious. The spikes activity. We're all carrying millions of germs, successfully in harmony or unsuccessfully presenting symptoms. The move between the two groups is the spike's activity tearing the endothelial membrane as it circulates in the blood flow. So coming on to the more specific point here, arising as a result of your talks, fewer symptoms when germs are multiplying in the endothelial cells, more symptoms when endothelial cells are bursting due to the pressure of germs, releasing neurotoxins. Is that something that you would agree with?
That's a very, go ahead, I'll go to you.
Dr. Mao, sorry, I didn't hear that.
Okay. I think that's a really interesting observation or hypothesis, which I have thought a lot about myself in the context of Bartonella infection, which one of the places where it resides is in the endothelium, in endothelial cells. There's a lot of psychiatric and neuropsychiatric manifestations described with COVID, acute infection, as well as post-COVID / long COVID. There are different mechanisms that have been hypothesized, including, and we talk about this in our paper, direct effects of the virus or remnants of the virus, say spike protein, an immune response to those two things, similar to what Dr. Greenberg described in PANDAS, and then also activation or reactivation of latent infections. So certainly that's been described with Epstein-Barr virus and SARS-CoV-2 or other herpes viruses. But in fact, also for Bartonella, there have been a couple of papers now that have described activated, reactivated Bartonella in the context of SARS-CoV-2. And that was detected with next generation or metagenomic sequencing. And so I do wonder if, just as one example, the neuropsychiatric and psychiatric manifestations of COVID could, at least in some subset of patients, be due to that mechanism that was just described, where spike protein, the vascular endothelium is being damaged, and these intracellular Bartonella can then be so-called released and either cause direct effects or an immune response, which is a common theme that keeps on repeating itself, that a lot of this symptomology seems like it could be related or is known to be related to actually immune responses to the organism rather than direct effects of the organism itself.
Thank you very much. That makes a lot of sense. Fascinating. And Dr. Bransfield, you were talking earlier as well about the neuropsychiatric effects that you've seen related to SARS-CoV-2 / COVID. I don't know if you want to say a word or two about that.
Yes, I think if you look at COVID, Lyme, and HIV/AIDS, they all have similarities in that they're all immunosuppressant in different ways. And that immunosuppressant activity, now one thing it contributes to, if they're immunosuppressant, you have limitations of immune-based testing with an immunosuppressant agent. But when they're immunosuppressant, then they could activate other things. So Lyme we may have Bartonella in us, and Bartonella could be activated, for instance, with HIV, or it can be activated with Lyme. And then you may treat the Lyme, but then once the Bartonella gets activated, then you have another problem you have to deal with. And COVID, you see that too, where people that were treated for Lyme and they're stabilized, then they get COVID, and now it reactivates their old Lyme. And even though there's an overlap of Lyme and COVID symptoms where there's a lot of similarities, there are some differences. And you can see the pattern that goes somewhat more with the Lyme symptoms that reemerge after a COVID infection. So it's, I like the phrase complex interactive infection, because there's a lot of ways when you have 1 + 1, it equals 11 instead of 2. When you have multiple infections, because of the complexity of these interactions, some of which we have some understanding of and some of which we have no understanding of. And when you have a tick-borne disease, you get a mix of these different agents. It's not just Lyme, Borrelia, it's a mix, some of which probably we haven't figured out yet. And someday we will, but some of the ones that we do figure out, we see Lyme, Borrelia, Babesia. Now, the Bartonella probably isn't so much carried by ticks, but carried by other vectors, which is in us. And that could be activated similar to opportunistic viruses. So you see a lot of times someone gets Lyme and then activates different viruses. You treat the Lyme and then the viral titers drop. So it's really a very complicated formula.
Is this recognized more now in the US by the regulatory authorities, by child protection services and so on? Or I know it's state by state to a large extent there, but we still have great difficulty in the UK with this being recognized officially, and too often children are just given psychiatric drugs and sometimes even sectioned as a result of their behavior.
Well, if you
Things
look at
like
those
this
three,
changing? Sorry.
well, I have been involved in a number of cases where there were allegations of Munchausen by proxy, and we've always won these cases. And it's usually, you can't really create Lyme disease. It's contrived illness. You can't contrive it. It's impossible to contrive. You can contrive toxicity, but you can't contrive an infectious disease unless you inject an infection. And so it's an inaccurate label, but yet we saw that. And basically, it's someone who annoys a pediatrician, and then they contact social service. And there's a disagreement about the etiology. And I've seen some really bad results where they took the children away, and then you saw neurological deterioration because they didn't get adequate treatment. And I think there's less than that now than there was. I think there's still some in Netherlands or certain parts of more Northern Europe where you see more of that, where people don't grasp this. We addressed that in an article of psychosomatic, somatopsychic, multisystem illness, and medical uncertainty to try to sort that out. And people don't have a good handle of that interface between mental illness and somatic illness. But it's a lot of times these mothers, it's similar to what we used to do in psychiatry, where we would say schizophrenia was the result of the schizophrenic mother, because the schizophrenic mothers would hoover over these children. But it was really the opposite. They knew they were impaired, and they hoovered because they knew they had to. The mother didn't cause it. The mother was trying to help compensate when other people didn't understand it. So it's a tragedy and an arrogance on the part of some people that don't understand it, and it's abuse of the legal system.
Yeah. Well, I'm glad to hear that you do feel things are changing gradually, perhaps because of the tragedy that we've seen over the last 4 years. A question here, very important one, really. Have you seen good results with natural remedies for PANS and PANDAS? I know Dr. Greenberg, because that was primarily your talk, your section of the talk. Perhaps you'd like to begin by addressing that.
I have seen that play a role, and I think natural stuff is very important, very helpful. But it will depend upon, what the causing agent is and how many causing agents you have. Some of the kids I see with tick-borne illness, I look at them and I think you almost need to blast them with antibiotics. And some other kids, they get a drop and it causes a Herxheimer, an intense reaction because they are so sensitive to the bug. And so it's often a mixture of the two. And generally, I tell parents, if you're spending time with one practitioner, and I think everybody has a different piece of this puzzle. I don't think the studies on kids really have been done that are good and help guide us. So, and kids are not little adults. So if you're seeing someone and after 6 months, let's say you got better, but you're at a plateau and you're not moving, then it may be time to go see someone else because somebody else has a different view of this. So I do think natural things are very important, but usually an antibiotic is needed. I've yet to see someone who got, well, no, I take it back.
That would be in PANDAS, presumably, and when it's a bacterial infection, or do you even see the viral infections requiring, because they've become bacterial?
Well, it gets very tricky because, like, a lot of what I see are tick-borne illnesses, and especially Lyme, Bartonella. What they do, as Dr. Bransfield said, is it's like the floodgates gets open because they're immunosuppressive. So you will have elevated Epstein-Barr titers and other viral titers. But to just go after the viruses, you're missing the boat because you really need to repair the immune system. And that will require treating the other tick-borne infections. And you'll find, as Dr. Bransfield said, once you do that, treating the Lyme or the Bartonella, these viral titers will go away. They'll be normalized. And that I've seen many times.
And the nutritional aspect as well. There's another comment by a doctor here that the craving for sugar, for example, required for the germs to grow is seen and is obviously a huge factor too.
The craving for sugar has been seen in a variety of different types of illnesses. People attribute it to fungi many times, but also, Mannalia in the gut, but also in bipolar kids, which was my first area of study. The kids who are depressed crave sugar. They will hide wrappers under the bed. They will just sugar all over the place. They eat all the Halloween candy in one night. They must have it. When they're no longer sad, they are able to have much more self-control. And I think this really all speaks to whatever's going on in the brain by the hypothalamus and affecting, hunger or satiety. I think it's much more complicated than we realize at the present time. I do think a lot more people are sensitive to gluten. And that's important to look at because the gluten-restricted diet can help the immune system in those who are predisposed, without question.
Yeah, another therapist has written that she finds a real anti-inflammatory diet very helpful with no processed food. As you've just mentioned, no gluten, no dairy, no mineral salt, no cooked oil, sugar, and ideally plant-based. Have you noticed the benefits of that too?
Well, I put it this way. My feeling is whatever works is the right answer. And I think it comes from different parts of medicine. And what will be great for one child will not necessarily be helpful. But there's no question that eating a diet that is less processed food is just plain healthier.
Yes, yeah. Thank you very, very much. Another therapist writes here, please say more about what Bartonella does to the endothelium, brain, spleen, pericardium, and muscles. Is it in the endothelium body-wide?
Well, it can attack the vasculature. And so you can see angiomas. And that's why you see the stria. And one question is, like when you have Lyme, it could be in the body, in the brain, or these infections in general, in the body, in the brain, or the vasculature. So you particularly think of vascular effect with the Bartonella. And then that affects circulation, so it's a big problem. You get it's in endothelium. I don't know if anybody else wants to say more about that, but I see a lot more vascular issues with Bartonella than with other infections.
Yeah, I'll say the endothelium is considered a primary niche for the organism. So the way that it is transmitted is it's a vector-borne infection, and there's a variety of arthropod vectors, but fleas on say cats or dogs are felt to be one of the main vector for Bartonella hensley, and what happens is that the flea deposits its feces on the cat's or the dog's skin, and then say with cats, they're grooming themselves, they scratch, and then they scratch a person, and that can then transmit the Bartonella organism into the dermis, into the skin, and then from there it gets transported, say by maybe dendritic cells in the skin, to the vasculature, and specifically to the vascular endothelium that is recognized as a primary niche for the organism. And this organism. From there, the endothelium can then spread to other sites where Bartonella goes. And in fact, the red blood cells are a place where Bartonella can go intracellular. And when it does that, it actually is protected from the immune system because basically, I'll just try to do a little nutshell description. Red blood cells mature red blood cells do not have a nucleus. So they don't have something called major histocompatibility complex 1 or MHC1 on their surface. MHC is also sometimes better known as HLA markers. People have probably heard of those. But this MHC1, what it does is it actually serves as sort of like a flagpole, I've heard it described as, on a cell, that when an organism invades the cell, parts of the organism get broken up and they get lifted up onto this flagpole to tell the immune system, hey, I've been infected and invaded by this organism, come and respond. So red blood cells don't have this. And if they did, then what would happen is CD8 positive T cells, the cytotoxic T cells, come and take care of the intracellular invader. So Bartonella can be both in the vascular endothelium, which then can also seed into the red blood cells. And they can be relatively, quiescent, if you want to say, inside those red blood cells.
I understood.
Now, we'd spoken about Bartonella, but there was a number of articles a number of years ago about cat ownership correlating with psychiatric illness.
Oh.
And they were then, especially schizophrenia. So they were correlating that with toxoplasmosis. That was one of the things we wrote about, although we haven't discussed it much today. So toxoplasmosis can go with cat ownership, but so can Bartonella. And which of the two is it, or is it an interaction of the two? So if you're a cat owner, you're more likely to get both Bartonella and toxoplasmosis, which is associated with psychiatric illness.
That makes sense. A question here from a participant. Could the vascular issues you've just been discussing actually cause migraines?
Oh, migraines?
Yes.
Yes, I mean, I think all of these, we've seen that with Lyme and Bartonella for sure. That one of the symptoms is migraines.
And what about the, I'm sorry, did you want to say something else?
No, just that when you get these infections, they often affect the autonomic nervous system and the vasculature. And so you get many different changes, including POTS, postural orthostatic tachycardia. The person may feel weak, dizzy, a whole bunch of systems in the body become off.
Yeah. And what about the involvement of mold in these kinds of conditions? This question specifically asks, how does mold exposure aggravate Lyme or vice versa? And are there any particular Lyme infections or co-infections that are more synergetic with mold and mycotoxins?
Charlotte, you want to take the mold question?
I have developed quite an interest in mold and mycotoxins and the intersection of those with Lyme and Bartonella in particular. So I do think that certainly anecdotally, you will hear from both patients and clinicians that there is some kind of interplay going on where, say, someone could have these infections. They can be asymptomatic. I just mentioned Bartonella. It can be quiet, in the red blood cells, not causing you problems, almost like it's part of your microbiome. And then some other hit comes along. It's a multiple hits model. And it could be, I do believe that mold and mycotoxin exposure can be another hit that can, similar to what I described for SARS-CoV-2, that it can then activate or reactivate these infections that were previously latent or dormant. Mycotoxins, they are toxins and they have a very wide variety of effects on body systems and on cells. And so again, if they have, say, effects where they cause lysis of a cell, and you have, as we talked about before, an intracellular infection that was dormant, latent there, that could then be released, so to speak. So that would just be one hypothesized mechanism.
And one perhaps related question, if we have time to overrun by just a couple of minutes, is yeast an important pathogen as an autism trigger in gastrointestinal conditions? This doctor has seen a few cases where nystatin benefited the patient and other natural antimicrobials.
But certainly a concern when you give antibiotics, and then you can increase yeast overgrowth. And if the person does carbohydrate craving, that also contributes to yeast overgrowth. So that's, although there is some evidence for fungi infection with mental illness. That was on our list.
Oh, yeah.
And, but go back to those three circles again. There's the infection and other disease drivers, other things, and then the immune system, and then the symptoms. So it's like a tangled ball of string. And how do you untangle it when it's so complicated? And after you do it long enough, you kind of learn the usual patterns of where you start, and you work your way down a list. So sometimes you start with looking at the disease drivers. And what initially started it may be different than what perpetuates it at a later date. Okay. Yeah. And then you look at what's going on with the immune system to normalize immune functioning. So that's like friendly fire in a war zone. And a lot of the symptoms are immune mediated. And then look at the symptoms, and what are the symptoms that keep someone stressed out and more immunocompromised, often sleep deprivation or whatever chronically stresses the person.
Yeah.
And then you're working your way down a list and looking at what seems to be the biggest disease driver right now. What intervention can we do that gets more benefit and less risk? And what do we do in what order? Because you can get, my average Lyme patient has 80 different symptoms.
Oh, my goodness.
I'm not going to give 80 drugs for 80 symptoms, but what's the more pivotal thing? There's a quote by Osler that the young physician gives 10 drugs for one condition. The older physician gives one drug for 10 conditions. Mm-hmm. And I'm an older doctor now, so I try to give one drug for 10 conditions. But it's really, you're trying to give one drug for 100 symptoms, because that's what a lot of Lyme patients have. Okay.
Yeah. No, totally understand. Maybe just one last question, and thank you so much, everybody, for your questions. I realize that we haven't managed by any means to answer all of them, but this one perhaps directed towards you, Dr. Bransfield. Do you know of any psychiatrists who might be interested in conducting randomized double-blind clinical trials on vitamins, nutritional supplements, and herbs that help with mental disorders? Is there any chance of that, or is that because they're not patentable that this just doesn't ever happen?
Yeah, you're right, because that would be a fair expense and no one would want to pay for it. And the other problem, here's a problem, and this was the problem that came up with the Tuskegee trial. Once you basically know something, it's hard to do a double-blind trial. And that's what happened with the Kempler trial with Lyme disease. And there, they took people that were PCR positive for Lyme disease, and they were excluded. And those were really the persons that should have been included, but they were excluded. But it was seen it was unethical. So we know enough. It's hard to do this. You'd have to have someone who would finance it, and that would be the hard part. And so, but it's also hard when you know something works to really ethically have a placebo group.
Yeah, that's often the case, isn't it?
Yeah.
Thank you so much, all of you, for this absolutely stunning roundtable. So many.
And thanks for what you do for bringing this information to all of us. We've all enjoyed your conferences in England and glad that we went there with colleagues. And thanks for all you do on a regular basis.
Oh, thank you so much. Well, just to mention to everybody who's been asking, this will be recorded, and all of the speakers have kindly said that we can put up their slides as well next to the recordings. So this will all be available in the next few days. And just to mention also that a few additional questions specifically about Lyme disease did come in also earlier. And there will be a chance for us to ask those on the 9th of October when Dr. Armin Schwarzbach will be talking about the adaptive immune response in Lyme borreliosis, together with Professor Gilbert and other speakers. So that, which had to be postponed for specific reasons just a little while ago, that will now be taking place on Wednesday, the 9th of October. So thank you very much, all of our audience, for being there as well and for all your questions. And thank you so much for this fantastic roundtable.
Thank you.
Goodbye. Thank you.